Thank you for that nice presentation. I want to thank you for the invitation also. I am Rafael Barrera. I'm the director of SICU of Long Island Jewish Medical Center for Northwell Health in New York, the COVID pandemic in 2020. And our hospital was the receiving hospital for most of the patients in the tri-state area. So we're going to talk today about our experience with the COVID-19 pandemic of 2020. We, as a service, are the acute care surgery team and the SICU team in Long Island Jewish, which is a 13-bed intensive care unit. We can expand to 17 beds depending on the day. Usually Tuesday, Wednesday, and Thursday, we have around 110, 115% higher capacity than we actually have. So this is our hospital. Our health system has 21 hospitals, and it basically is in Manhattan, Queens, and Long Island in New York. Beginning in March, we began treating the COVID patients, and we, as I said in my introduction, were the epicenter of the pandemic. LIJ of the 21 hospitals treated the most hospitals in of the system. This is the timeline of COVID. In December 31st of 2019, there was a unknown pneumonia reported by the WHO in China. Then in January 13, the first case outside of China was reported. In the US, January the 20th, the first case reported. And in New York, the first confirmed case was March 1st. The pandemic officially started March 11, 2020, when the WHO classified it as such. This was basically our problem. Our hospital ICU division was running at 375% of its usual capacity with a continued rise of 10% per day. So basically, when the MICU was overwhelmed and medicine was overwhelmed, the surgical department was called to organize the staff into a tier system based on the SCM guidelines. We basically have 5 ACS SICU attendings, 80 residents, 25 surgical PAs, of which they all are critically care trained, and we have 18 non-critical care surgeons who had some experience in critical care during their residency. What we did is we trained them quickly to the non-critical care surgeons. We had a refresher course, and at the time, whatever information we have available for COVID, and we had weekly video conferencing for the non-intensive surgeons to start doing the work. This is what we did. We took we took the SCCM guidelines, as you can see on the right of your screen, which is basically how they were managed 24-bed ICU, and we took that idea and made it into ours. You can see our triangles are 4 intensivists who manage 3 ICU teams, which each take care of anywhere from 12 to 17 beds. All of the teams had 1 critical care surgical PA leading, with a non-critical care attending with the residents, respiratory therapists, and such. We had no issue with PPE in our hospital because of the administration and the supply chains that Northwell was available. It was very very good and very well managed. This is the surgical PAs, the non-critical care surgeons who pose for a picture, and this is what we did. We had our lobby basically transferred into an ER, and on the right to the screen, that was the surgical department's evaluation for patients that needed surgery. Just remember, in New York, everything was closed. The hospital became a COVID hospital, and we had minimal surgical operations during 3 months. As the rapid responses that usually are 100 a month went up to over 600 per month, we created a new ICU with 64 beds. You can see on the screen when it's empty. And on your right of the screen, we have a 64-bed ICU that was all negative pressure, and everybody was there, plus the patients that were in the regular ICUs. We created a proning team with all the surgical techs who have experience in proning. The skin protection team was created secondary to the skin team that we have plus nurses that have minimal experience in critical care. And every time, so they worked in unison with the pruning team to protect the skin of the patients. That was very successful. We also created a NOTA team, Nobody Dies Alone team, for the nurses that were very helpful with the family members, with conference calls, so especially at the end of life. Patients were allowed only one visitor. It was a very stressful and sad situation, but the NOTA team was very instrumental in at least giving some peace to the patients. This is our how the LIJ managed the patients. In April 13, we had 723 patients. April 22nd, 500. May, 215. As you can see, the ventilators in April were 110 and went down slowly, and the ECMO patients went up. Our discharge data at the time was 12% up to 17%. As of June 17, we had 32 patients on the floor and 4 ventilated patients. The worst week was the April 14th to the 17th, where we had 900 COVID positive patients in the hospital. Our hospital is only, it has capacity for 500 patients, and we have 152 ventilators in use. A total of 402 ventilator patients were treated. And below you can see the curve of the volume of our patients as they went in, and the rapid response and anesthesia volumes. Between March and April, most of the rapid responses require intubation of such patients. This, at the end of 90 days, Northwell treated over 10,000 patients. LIJ treated 3,000 patients. We discharged over 2,000 patients, and we had most of the patients that were discharged to facility had tracheostomies and PEGs. Currently, right now, we only have 20 COVID positive patients, of which 4 are ventilated and 2 on ECMO. This is the last treatment algorithm that we have, as you can see, because Northwell, especially LIJ, is a teaching hospital. They were all experimental drugs. You can see there were different arms of trials, and these algorithm treatments are being updated as of next month, waiting for a potentially second wave. As you can see on the right side, we recommend against a lot of the drugs that we started using, and some of the trials were positive, and some of the trials are still being analyzed to see if we can help. I just put this slide not to forget the heparin or the Lovenox. Everybody needs very aggressive prophylaxis, and most of them will require a heparin drip or a Lovenox. This is one of the articles that Northwell came up with in JAMA about outcomes of over 5,000 patients with COVID, and you can see there was a mortality around 25%. These are other 2 articles that were published also with a mortality of about 26%, except the problem with all these articles is not a complete picture of all the patients that were ventilated at the time. This is the article. If you don't understand this lecture, we actually published this in Surgery, applying the triage principles of mass casualty events to the COVID epidemic. This is our experience with our team of ACS CQ attendings and how we escalated and helped the medicine department manage. At the end of 90 days, we treated 55% of the COVID patients. So I can clearly tell you that the surgeons, the ACS surgeons and LIJ have high expertise in treating COVID patients. This is just a reminder of, because we were so overwhelmed, we had most of the information on the windows of the patients. The most important information, weights, vents, ABG, what sedation, and what pressors. And we relied heavily on a good window and markers. We created a bunch of protocols, medical management protocols, palliative ethics protocols. That's very important. If there's a second wave, we already have everything in place, tracheostomy, PEG protocols. And of course, now we're dealing with the post-COVID outpatient clinics that surgery is not involved, but medicine is involved, because there's a lot of other medical problems that these patients have that have not been reported yet in the literature clearly. During the pandemic, we were working on the recovery strategy. As you can see in yellow, we were prepared for a mass casualty incidence. We never thought that it was going to be that bad. We were always preparing for maybe, because of New York, a terrorism attack or something as such. That has not happened, thank God, but we never thought of a pandemic. So we were working in unison with the emergency management response. And then when the COVID operation started, at around 1 month, we started planning recovery and recovery implementation that continues to go on, because the problem is right now, there's thousands of cases of surgical cases that were delayed secondary to this pandemic. I just wanted to put this slide in to mention how we learned how to treat this patient. Not all patients need intubation. Can we avoid it? Maybe. High flow is one of the options that seems to work very well with the patients. At the end of the 60th day, we started using the high flow, not BiPAP as much, and the patients seem to be very receptive to this mode of ventilation. And we haven't compared the outcomes. We're doing it. It seems that it works. This is a very important slide. During the first wave, we learned gradually how to treat these patients. But the second wave, before the real second wave comes, there's a minimal second wave, the impact on resource restriction in the non-COVID chronic patients. That is also impact on the surgical cases that were not done. The third wave is the impact of the chronic conditions, dialysis, all these patients that now have delayed treatment. And now what we're doing is, for the fourth wave, is the staff. Burnout, compassion fatigue. We created a program for compassion fatigue for mental illness, because there was some of the patients would have post-traumatic, some of the attendings, residents, nurses especially, with not burnout or PTSD, but some stress. So we created programs to treat this patient, these staff members, and we're waiting to see if it works, if there is a second wave. So how we're moving forward? We are prepared. We continue to plan, and we are ready to implement anything we learned with a second wave. We have research data, and the new algorithms of care are coming out by the end of the month. We're educating everybody again. We're having the non-intensivist groups, the surgeons, the PAs, nurses that don't do critical care. We're ready. We're training. We're educating, and we are actually teaching a lot fundamentals of critical care management for the nurses on the floors, especially, and hopefully we won't have to use it. So at the end, it was a very hard learning experience. If there is no second wave, we'll be very happy. But if there is, we'll be ready. And the only way to be ready is to be ready for the worst. And hopefully with planning, with education and implementation, we can succeed at controlling the second wave if it comes. Thank you very much.